I love doing that stuff.
Kelly.
Thanks. All right. All right, my name's Kelly Joplin. I've been with CoxHealth Systems for about 27 years almost. Most of that has been respiratory care, and most of that time's been in adult critical care, respiratory care. So I've done a little bit of NICU, PICU early on, and a little bit of everything in the beginning. You kind of jump in and do it all. So my main focus for the past at least 2 decades has been mechanical ventilation on the adult patient, and invasively or non-invasively, and all kinds of modes, ventilators, different adjuncts, independent lung ventilation, and it goes on and on and on, all kinds of little tricks you can do in the hospital. So what we'll talk about today is mainly with this handout is some real basic approach to mechanical ventilation. So anytime we're using an ambu bag, and we're managing an airway, whether you've put an artificial airway in or not, or using some kind of adjunct to create patency and you're bagging them. But as soon as we're bagging them, we're introducing some positive pressure. You know, we're squeezing the bag, we're trying to synchronize with them if they're breathing and try to offload the work of breathing. And we're doing this to oxygenate and ventilate them. So when we use an invasive mechanical ventilator, we're already under the assumption we've placed an artificial airway. So you probably intubated them. And then you're going to start a mechanical ventilator. So the key with mechanical ventilation is you need a patent airway. So if they're biting down on the tube, you need to put a bite block in or something that keeps them from closing their airway. And then you need the vent to be working. And even if it's on room air, if it's just using a turbine and it's just using atmospheric air and it's just about 21%, but you're needing it to cycle. And when you run the vent, you're going to try to ventilate and oxygenate your patient. So let's start at the top of your paper you've got. And so first, just some definitions. FiO2, we hear that term all the time. That's your fraction of inspired oxygen. So either got a flow meter and you're bleeding O2 into your ventilator, or you have a ventilator hooked to compressed medical air and maybe even oxygen both. And then you can dial in the actual FiO2 or the oxygen percentage you want to deliver to the patient through the ventilator. So meaning every time they get a breath, they're going to get this much oxygen. Now, most of the time on the ambulances and in the war front, when you're in a hot zone, those vents generally you're either not entraining any extra oxygen or it's just literally that. It's almost like a liter flow with like you do with a cannula. And in those cases, you're just turning it up. It's like a bulk flow thing. You turn it up if you think they need more. And you'll have some kind of limit. It'd be self-limiting. And that's being mixed into the ventilator, which is high pressure or a pressure system and usually higher flows. So it dilutes down the amount of oxygen they're actually getting. Now, the vents I've seen you guys are going to be using are nice. They're real compact. And they're pretty straightforward. And as far as the oxygen delivery, you can bleed in oxygen with those ventilators. It's almost like adjusting a cannula when you're bleeding in the oxygen into the system. So now the positive in expiratory pressure, that's PEEP. So when you think about oxygenating a patient, especially whenever you're fast tracking them, you know, you want your basics. You got to have a patent airway. It needs to be getting in there. If they have a pneumothorax, you need to relieve that. If they're in a cardiac crisis, you're going to have to deal with that or they're not going to oxygenate well. But concerning the vent, you're looking at their amount of oxygen you're giving them and then usually the amount of PEEP, the positive end expiratory pressure you're giving them. So when you hear the term PEEP, PEEP is a continual pressure that's held into the lungs. Now when they go into exhalation, so they're not getting inspiratory breath, it's time for them to exhale, they'll still get that positive end expiratory pressure level you've got dialed in. And whenever you give them a breath, it's going to be given on top of that PEEP. So the amount of volume and flow over time is volume. So that's being delivered and a pressure that's given on top of that PEEP. So those will be combined. So, and that's on your paperwork there. So then the next thing you have is your frequency, your rate. So your vent's going to have a rate you could set. Now I know with the vent we messed with the other day, that's kind of a EMS, a transport type vent, little bitty thing, and it was set up to where you pick a height and it automatically will shoot for 6 mLs per kilogram ideal body weight of that height. It's built into the ventilator. But we learned another thing about that vent too, is that it seems to have some kind of self-limiting formulary in it that it won't let you deliver more than 8 liters, an 8-minute volume. So the reason that's significant is when you have patients that have the acidotic type situation, whether it's a metabolic acidosis, a respiratory acidosis, a mixed acidosis, things like that, if they have a drive to breathe, typically they're going to be rapid. And that creates asynchrony, issues with the patient and the ventilator where it's not cycling together. So even if you don't have blood gases on the MS and you are using end-tidal, or if you're not using end-tidal, if you're looking at those patients, so it's your trauma patients, your potentially septic patients for all kinds of reasons. We know there's UTIs, urosepsis, there's dead bowel, there's traumas that produce lactic acidosis, shock in general, lactic acidosis, and then not the DKAs, it keeps going. So acidosis generally, as a general rule, if that's what you think you have, you need a higher minute volume for that patient. Now, if they're generating that minute volume, you're trying to offload their work of breathing. But if they're not and you're doing all of it, you're setting up all the settings on your vent, you try to go with the highest minute volume you can deliver to that patient without trapping a lot of air. Now, on the ventilator you'll have on the ambulance, you won't necessarily have graphics that show you whether someone's trapping air. But you will be able to identify if you think a patient needs a higher minute volume and go for the highest you can deliver, that you think you can deliver. So on the tidal volume, so evidence-based science indicates that we should run tidal volumes at about 6 mLs per kilogram of body weight under the guise of a lung protective strategy. So what they've learned over the past several decades is we can cause harm with a ventilator. We can induce harm, and there's all kinds of categories. There's volute trauma, barrel trauma, atelectatic trauma. It just keeps going and going. So the main thing you need to know about a vent when you're trying to protect a patient from harm from the ventilator is shoot for about 6 mLs per kilogram of body weight or less. And keep your peak pressure, and we're going to talk about all these different pressures, your peak inspiratory pressure, the top pressure coming from the vent, at 30 or less, and that's on your paperwork. You want that. And then with PEEP, generally most patients when you're out in the field, you're probably going to be running PEEPs between 5 and 10 most of the time. And there's anywhere in that range. If there's an oxygenation issue and you don't think you have a pneumothorax that's going to turn into a tension pneumothorax, then you're looking at probably turning the O2 up, turning your flow rate up on what's going into the vent, and turning your PEEP up. If you're on 5, go to 8. If you're on 8, go to 10. And give it a little time and reassess your patient, because the positive and expiratory pressure, that pressure is being kept in the lungs on exhalation, can help restore some of their functional residual capacity in their lungs or the surface area in their lungs for gas exchange while they exhale, because we tend to lose a lot every time we exhale if there's not enough pressure in there. And so with your ventilation's usually going to be driven by your rate you have set and the tidal volume they're getting, and those combined create a minute volume. So if that minute volume is effective, meaning it's not creating a lot of dead space, it's not causing them to trap an enormous amount of air like you see in a COPD or a status asthmaticus patient. Those patients, like COPD exacerbations, a status asthmaticus, you can try to give them a higher rate, but they'll just trap more air, right? So usually you're just running regular rates on those patients during their acute phase and just rapid them to the hospital, because they're probably going to need paralytics, maybe heliox, all kinds of little things that we're not going to have on our ambulance. So as a general rule, when you put them on a vent out in the field, PEEP and FiO2 to oxygenate them. Rate and tidal volume to get your minute volume to ventilate them. If you think they're acidotic, if that's what your gut feeling is, that's what your assessment is, give them the highest minute volume you can give them. If they seem really dysynchronous, like they're very uncomfortable, and you don't have any way to knock that down, then you try dropping the rate to see if that creates more synchrony. Because a patient that's already having a problem breathing, you put a tube in them, Now there's more airway resistance because the tube's in them, unless they already had a patent airway before you tubed them. So if the endotracheal tube created a patent airway, that should reduce some of their work of breathing and their ability to ventilate and oxygenate. But if that tube is small, you're going to trap more volume, because whenever they try to exhale, they meet resistance of the tube. It takes longer to get it out. It's just like when an asthmatic has bronchospasms and swelling in their upper airways and it's tight, their lungs are working like a one-way valve. Get area and can't get it out. So in the hospital, we have to put on Heliox, a less dense gas, to get it to pass through those tight areas, because those are density-dependent areas. An endotracheal tube is density-dependent. So when you put a smaller tube in somebody, you're going to have a problem putting a high ventilatory rate into them unless the tidal volume is really low. Does that make sense? So bigger tubes are good. You can move air easier with a bigger tube. They can always downsize it. So PEEP and FO2 for oxygenation, rate and tidal volume for ventilation. You're going to be limited with these vents. The vent I've seen that you're going to use, again, it capped out. Every time we tried to combine a rate and a volume to get beyond a minute volume of 8, it wouldn't let us do it. It would actually drop the targeted tidal volume. So it already had its own built-in formula. So if I jump the rate up to 20 on a given height that I had at a rate of 12, it's going to drop the tidal volume down to where that rate and that tidal volume gets 8 minute volume of 8.0. So it's automatic. It's kind of good, because a lot of times when you're up in the rate on somebody, you also need to drop the tidal volume to some extent. It just depends on the patient and how much you have to use to assess what you need to do. So that vent is doing it for you. That's actually superb. That's a great idea. So let's talk about these 3 gases that Brant wrote up there. So on the top one, 725, 15, 120, and 4. So that 15 is not happening on accident. So you're not going to have a patient that's apneic that's pulling the 15. Their CO2 would go the other way. So if you had that gas that's a metabolic acidosis, if you had that gas and the patient went into respiratory failure and their CO2 starts going up, that pH is going to get worse, more acidotic. It's going to get way over here towards the 6-8, all right? That's where you're doing CPR. So that gas, that right there, that patient that wears out trying to compensate, or you're giving them something that slows their rate down, that CO2 starts going up, they get more acidotic. So if I had a patient that I was even thinking was giving me that gas, so I'm being handed a patient that meets criteria for sepsis. My first thing I do on every patient that I think has sepsis, before I've had a blood gas or anything, now I have the benefit of putting them on a vent that's got all kinds of mechanics on it that I can see everything we're doing with it. I can see the lungs, how they're working. So mechanics-wise, I'd put them all on. I shoot for a minimum minute volume of 10 liters. So that means my rate and my tidal volume combination needs to get me to a minute volume of 10. And I don't have a blood gas yet. And I don't have an end-tidal CO2 monitor on them either. I just know that the doctor's given me a report or told me things, or I read their notes, and they've got markers that tell me they're likely septic. So if they're not septic and what I'm doing is blowing them off and they don't have any sepsis, no acidosis, they'll be alkalotic. I can back off the minute volume after I get the gas. But if they're septic, I'm already hedging them towards a lesser amount of, I'm trying to partially compensate. And the reason why is a severe amount of acidosis in an acutely ill patient can create more cardiogenic problems, more compromise. And a lot of these patients will be dehydrated. And so if you're dealing with cardiac issues and you're trying to give them meds for that and the patient's extremely acidotic, some of them won't be as responsive to what you're trying to do for them. So I'm just trying to hedge them a little bit. I'm trying to create a situation that's doing a little bit of buffering, a little bit of compensation for an acute problem they got. It's not a cure, it's not a fix, it's just a Band-Aid, but if you can do it, it can help your patient's outcome improve. Now on the one that's alkalotic, the one below it, 7.5. So the 7.5 pH, they're alkalotic. If they were 7.40, that's normal. So that's not a severe alkalosis. And their CO2 is blown down to 25. So it's on the alkalotic side of normal. So a normal CO2 is 35 to 45. If you see 40 is the mean, and they're on anything below 40, they're moving on the alkalotic side of normal. So the needle's moving to the alkalosis side, and they've got an alkalotic pH. That's a patient that if they're doing that on their own, they're breathing, right? So they're moving air. Now the one at the top, the acidotic patient, they're likely breathing fast, higher minute volume. But if that one on the top were not, say it was a ketoacidosis, a lot of them, the younger ones, a younger person, younger adult comes in, they have no pulmonary issues, their cardiac function's good, all that's good. They'll sit there and look like they're just calmly breathing. They'll look relaxed. They won't look labored. And we do a gas like that and then do some other tests and find out they're in a ketoacidosis. So you'll have patients that they're in failure. Their diaphragm's worn out, their accessory muscles are worn out, or they're just in a weakened condition by the time you got to them that they're just exhausted. And so they're to the point they're in failure, respiratory failure, they're too weak, and now you're going to offload their breathing for them with a machine. And so ventilation, oxygenation, patent airway, suction the patent airway, don't let them bite down on it and close it off. So in the EMS field, it's pretty fast and you can keep it pretty simple. And it's almost an advantage that you're not using an end-tidal, because in the hospital when we use end-tidal CO2 monitors, we really are supposed to get a blood gas to correlate the end-tidal and the PCO2 on the blood gas so we can see if it's accurate or not. Because you can have a good pleth, but if you have a good pleth, end-tidal CO2 reading, you think it's right, but the patient's got a labile blood pressure or labile body temperature or some pulmonary edema, things like that, that CO2 can be further off. You know, when a CO2, end-tidal CO2 is reading accurately, it's usually running and trending about 5 higher than the actual PCO2. But so many things change that, including it can be a false reading. So you're at an advantage if you can run even an iStat blood gas, which is a portable blood gas machine that, you know, could find its way in EMS down the road someday. The 725, are you guys doing that now? No? No gases yet on the ambulance? 725/80. So CO2's high. So on a COPD, a chronic COPDer that has been that way so long that they metabolically have compensated. So their bicarb and everything would be up, it'd be high. That's all right, I wouldn't worry about it. You'll see people, you'll have COPDers that they have a normal pH and a CO2 of 80, but their bicarb and base excesses stay on the high side. It'd be alkalotic all the time. And it's doing that to compensate for their chronic CO2 retention. Those patients don't have hardly any reserve when it comes to their ability to oxygenate, their ability of the lungs to their immune system in their lungs to ward off things. When you put them on a vent, you intubate them, put them on a ventilator, they usually need secretion clearance, they need bronchodilators. They'll PEEP on a COPD patient. Sometimes you use that to kind of splint some of their airways open, but at the same time it's a double-edged sword because positive pressure to an emphysema patient, they're already hyper-compliant. So when you put positive pressure to their lungs, you can hyper-expand them, right? So their blebs expand really easy. The ventilators, when you put a vent to lungs, the volume goes to the path, and the pressure does too, the path of least resistance. So when you have a COPD or you're putting on a vent, they're going to trap air. They already are. So they're going to trap even more. So you may have to run your PEEPs down there around 5 to 8 on them. You may have to run their rates normal, even though they're trying to breathe 20, 30 times a minute. You may have to run their rates down around 10 to 12 because they're already trapping so much air. The ventilator that I saw last time, you couldn't adjust your IE ratio. It had a default. So it seemed to continually adjust your inspiratory-expiratory ratio to where the higher you went up on the rate, the tighter the ratio got. So if you're on a rate of 12, it'd shoot for 1 to 2. 1 to 3, stuff like that. When you're on a rate of 14, 16, 20, as you went up on the rate, it got closer to 1 to 2, 1 to 1 ratio. It wouldn't go inverse ratio where the expiratory tidal volume is actually shorter than the inspiratory tidal volume, but it was doing that. It's kind of all automated. It's actually pretty good idea. So when you're going up on the rate, you don't have to worry about adjusting your eye time on those ventilators because it's doing it for you. And it's a real simple vent. It's literally you're picking a height, and you're probably either asking a family member, or you're measuring something, or you're measuring them, or you're guessing. But you'll pick a height, it automatically is going to shoot for 6 ml tidal volume. If you keep going up on the rate, it's going to start dropping the tidal volume range, and it should. And it starts changing the eye ratio too. You only have to think about it. And so that's a major plus. And then let's see, so you're not going to be getting gases on the ambulance. You probably won't be running in tidal. So here's my advice. This is what I would do right now, and I used to be a medic a long time ago. So if I were putting someone right now out in the field on a ventilator, and so I've intubated them and put them on a vent, if they look good to me, everything about them looks good. I just need to establish a patent airway. I'm not even sure why they're down. Then I'm probably going to run minute volumes around a 5-minute volume. Now remember, your minute volume is your tidal volume and your rate combined. That gives you a minute volume. I'm probably going to run them on a PEEP of 8 to 10. That's where I start everyone's PEEP. I can always turn it down. I wouldn't if I thought I had a tension pneumothorax or their mean blood pressure was below 60, and then I put the PEEP at 5. So now why 5-minute volume? Because a normal minute volume is about 4 to 6. So if you hit the mean, 5-minute volume is kind of going to generally produce the kind of ventilation you want out of that patient. FiO2, if it's a bleed-in system, so you've just got some tubing and you've got a flow meter and you're turning on to 6 liters, say it won't let you bleed in more than 6 liters. I'd start at 6. And once I have a pulse ox on them, if they look pink, they look good, and I don't think they have any carbon monoxide poisoning, I could wean it. I could turn it down. As long as their pulse ox, their SpO2 is running 90 or better, I'm happy. And they look pink, right? So the capillary refill is okay, things like that. Now, if I think they're acidotic for any reason, I don't care what the reason is, but if I think they're acidotic, metabolic acidosis, or they're a trauma patient, anything like that, on the vents you guys have, I would immediately max it out to a minute volume of 8. If that's the max it'll let you do, I'd do 8 on the minute volume. Because in the hospital, I'd go 10 until I got a blood gas showing me I could do less. And the reason why is most of these patients I've found over the past 2 decades, the acidotic patients, if I can produce an effective minute ventilation of 10 liters or higher, I generally do some partial compensation for their acidosis, meaning a mixed acidosis patient has an acidosis due to their metabolic issues and respiratory issues. So both things are acidotic for them. So they have a more severe acidosis. And so if I can do a little partial compensation, some of the other medications for the hemodynamics can work better. The doctors may not have to give them quite so much fluid, and they won't have to give them bicarb. So if I can hedge that where the doctor doesn't have to give bicarb, that's a good thing because now that's muddying up the water for the physician to make decisions over the next day or two. We got to give septic patients and trauma patients a lot of fluid. Burn patients get a lot of fluid. Well, and they need it, and you got to swell to get well. When you're really sick, you got to swell to get well. It's going to happen, or you're not giving them enough fluid. And so when you're giving them a ton of fluid, and their osmolality shifted, or they're malnourished, proteins low, things like that, or they're just at a severe emergent state, fluid shifts quick, and the lungs start having problems with water. Lung water goes up, and it goes up pretty quick. So those patients, if you think they're septic, acidosis, anything like that, a trauma, shoot for 8-minute volume. And I'm saying 8 just because that's what I saw the max your vent would go to. If you get vents in the future and go to 10, I always go 10. And so on your COPDers and your asthmatics, lower rate because you cannot force that in and out of them. The only way you can force volume out on a vent is you have to have what's called a positive exhalation valve or a positive exhalation system. None of these vents, we just have a few vents at work that do that. They're called oscillators. So it's going to be when we let go of the inspiratory pressure and volume and they exhale, what's making them exhale is the recoil of the chest wall, pressure from the diaphragm, and the natural elastance forces of your airways and your alveoli and your body, right? So that's what's making them exhale. If they're not breathing and assisting, then their diaphragm's not even pushing up. It's all just passive exhalation. So when you have that and you have asthma or COPD or a really tiny endotracheal tube, that expiratory volume is not coming out really fast. The only way it is, they got to have ARDS, really stiff lungs, can dump it quick. But outside of that, it won't. And so if you have a patient that you think has carbon monoxide poisoning, if you intubated them, I'd run the highest FO2 you can give them. I wouldn't turn it down. Because at the hospital, we'll put them on 100% O2 environment. We may take them across the street to hyperbaric chamber and put them in 3 atmospheres to try to get that carbon monoxide to displace, get out of the system, and get their hemoglobin to start bonding with oxygen, deliver oxygen now, because that carbon monoxide is taking up space and seats on the bus to get to tissue. And so it makes them, they'll get tissue hypoxic, or their lactic acid will go up because they're not oxygenating tissue. So if you have that type of patient that is on a ventilator, keep your O2 turned up as high as you can in the system you've got. Does that make sense? So it's back to get a tube in them. Make sure it's patent. PEEP and FO2 to oxygenate them. Tidal volume and your rate. So the amount of volume you're putting into their lungs and the amount of time per minute is how you're going to ventilate them. Okay? Watch out for these patients that are biting their airway. They're biting their tube. If they have teeth and they start coming around, if you've got the Thomas short-term, bite block, those are, in the hospital, hospitals don't like them. I do like them outside the hospital, and I like them in the hospital when you guys roll in with them. And this patient would be closing off their airway if you didn't have that in them. We can always take that out. So the right type of tube holder is important to keep their airway open, keep them from collapsing it down, and chewing through their pilot line. Let's see, I'm trying to think of unique scenarios. Well, and a lot of these you're going to need to be suctioning. I guess you guys you'll break the circuit and pass the suction catheter down if you got to clean them out. So if on the vents don't like secretions, and they don't like pulmonary edema rolling down them, right? So getting up into them and all this stuff because they have valves that stick and things like that. So when you have a patient that's got a lot of pulmonary edema or a lot of mucus, and this is going to sound really odd because we don't do this in the hospital, but unless you have to, but if it's just filling up the tubing, it's filling up your endotracheal tube, it's filling up your circuit, I think something like that, you need to put something on to protect your eyes and face, but point that tube in a safe direction, get a towel, pop it loose, let them get a volume and pop it loose and let that rebound pop all that out and dump that stuff out of your circuit. Because if you've got pulmonary edema or a bunch of mucus, a bunch of stuff in your circuit, it's going to affect the ventilator and the ability to have a patent airway. That stuff, starts getting all gummed up. So you do have a system that you wind up needing to clear out by way of suctioning or popping things loose and letting it fly out of there.
So our circuit doesn't have a trap or an inline suction unit on it?
I wouldn't assume that you're going to always have one that's got a Ballard and inline closed suction catheter. You could, but you know how it is. They make, next thing you know, you're not getting those anymore.
Right.
And then same with a trap. Sometimes there's a reservoir or a trap on inline vent circuits that's there to collect things like that. But some of them don't have it. To be honest with you, a suction catheter kit is cheaper than a closed suction and Ballard, than a closed suction catheter kit. A circuit that is just a circuit and you put an artificial nose in it, it's called a heat moisture exchanger to try to humidify some of that. That's cheaper than having a circuit that's reusable and has some kind of trap in it that, and these things have to be cleaned. So a lot of things, hospitals want all of us to have the best equipment anywhere. But the fact of the matter is there's budgets. And so a lot of times you don't count on having a closed suction catheter kit, because I've been in a lot of situations where you don't have that, where you're breaking the circuit to suction a patient out. And then as far as the traps, even if you have this circuit going to the patient and there's a trap in there that's just like a reservoir to collect whatever, pulmonary edema or anything fluidic, mucus that's going down there, a lot of them won't have those in the right place. It's too far away from the patient. And the circuit I've seen you guys have with this vent, I didn't see one in there. And if it was in there, it probably need to be before the expiratory valve and before the pressure transducer, because if it gets to all that stuff, it's going to mess up everything. So let's see, any questions? So you're at the advantage of, PEEP them and FiO2 them for oxygenation. Get the PEEP in there. Don't be afraid of PEEP. PEEP's a good thing. Then ventilation, same deal. The ventilation thing's either going to happen or they're just going to have too bad of lungs and need too high a minute volume, and it's just going to take time, and they're not going to cool off that minute volume, and you just got to wait it out. And it could be days in the hospital before we finally ventilate some of these COPDers. Offload the work of breathing the best you can. It's a lot easier to teach this if we had a patient right now and I was saying what I'd be doing and why I'm doing it, and then how hands-on the best way to teach. But start out simple. Keep it to the very, very basics. If your ventilator's not working for you, it's not working, it's dysfunctional, or it's not working for that patient, you can't find something that works, you go back to your ambu bag. We still do that in the hospital every day. If something's not working with a ventilator, or we're trying different things, different approaches, and nothing seems to work, then we have to take them off the vent, use an ambu bag, bag them, and then look for another avenue to treat. So it could be proning them, it could be moving them to another hospital for ECMO, it could be all kinds of, there's options. But there is a reason ECMO exists, where you're bypassing the lungs because their lungs aren't viable anymore. They're not going to ventilate and oxygenate this person. And so you've got to hook them up to lines and act like they're having open heart surgery practically. So when you have a patient that, if you're in a home and the husband's in there, the wife, the spouse is saying she's got really advanced pulmonary fibrosis. So pulmonary fibrosis, scarring of the lungs, they're really stiff lungs. They take in tiny volumes and they breathe high rates. Those are patients that have to have high rates, real low volumes, because their lungs don't expand anymore, and they have lost enormous amounts of surface area of their lungs for gas exchange. The COPDer has the other problem. They're hyper compliant. They're trapping a lot of air all the time. They're always having to work to breathe, things like that. Same with fibrosis to that extent. They work hard all the time to breathe. Acidosis patients need higher minute volumes. Alkalotic patients need lower minute volumes. Patients don't oxygenate well that are hemodynamically stable enough need higher PEEPs and higher FiO2. Minute volumes, shoot for 5. I'm going to repeat this stuff over and over because that's how you learn it. But minute volume, shoot for 5. If you're doing a range, 4 to 6 on the minute volume. Minute volume is a combination of your rate and your tidal volume. If you think they're acidotic, go as high as you can get that ventilator to go, 8 to 10 on the minute volume. And you can just do the math in your head, But any questions yet? None? Have you got to mess with the ventilators that you're going to be using at all? So when you do things like, just do exercises like that. Just sit there and dial in a height, and then look to see what kind of volume it says it's giving to the test lung, right? This test dummy. And then if you want a higher minute volume and you see what that is, then you just start making your adjustments. Experiment with that test lung. Drive the minute volume up, drive it down, turn the PEEP up, turn it down, turn the O2 up, turn it down. You need to mess with it and know the limits of that machine. You need to hear the alarms on that machine and know what they sound like. Because you're looking somewhere else that's alarming and you'll know if that's a really serious alarm or not. Does that make sense? I mean, you already do this with other things now, so you're just adding another tool. And a ventilator is just a bridge. You're bridging them over. It's life support. It's a bridge. It's not a cure, not a fix. It's a bridge. And you're just trying to do it safely.